Hello, and welcome to this CAPE webinar that we've entitled Hiding in Plain Sight, Detecting Rare Metabolic Disease in the ED. My name is Dr. Eddie Lang. I'm an emergency physician in Calgary, and it's going to be my pleasure to be your moderator for this webinar. I'm a professor of emergency medicine and the department head here in Calgary, Alberta. I'm also a researcher with the Cummings School of Medicine. Really thrilled about tonight's program, but first let me share my disclosures. As you see, I do receive research funding from CHR and Alberta Innovates. I do receive Speaker Bureau honoraria from industry, as well as advisory board and consulting work. But I just wanted to emphasize that all funds and honoraria and consulting fees I direct to the Calgary Health Foundation in support of our research funds, as well as to the CAPE Advancement Fund. It's my pleasure to introduce our guest expert speaker tonight. Dr. Anil Khan is pediatrician and medical geneticist with MAGIC. That's Metabolics and Genetics in Canada, based in both Calgary and Vancouver. He's an adjunct professor in pediatrics at the University of Calgary and with the Cummings School of Medicine, and is a metabolic consultant with the Saskatchewan Health Authority, so works across 3 provinces. Very impressive.
Thank you very much, Dr. Lang. It's a pleasure to be here. I'll go through a few disclosures before we get started. I have received a combination of travel grants, consulting fees, and research funding from the organizations you see on your screen. I'm also an advisory board member for a number of organizations that are support groups and international collaborative groups. As well, I have royalties for a gene therapy technology for Fabry disease, connected with the University Health Network. I have a patent in cell-free mitochondrial DNA testing. I have commercial holdings in my clinic, in my sequencing lab at Discovery DNA and Maternal Genomics. As well, I do consulting work across multiple provinces on different committees.
For this particular webinar, this is our global question that we feel you're going to be comfortable answering by the end of listening to us. The key question for us is, why would emergency physicians care about metabolic conditions? Anil, most emergency physicians will say, we don't really need to know about rare metabolic diseases. Why should they care about this topic?
Well, Eddie, while it's true that on a day-to-day basis, most emergency room physicians will not make a diagnosis of a metabolic disease. In fact, many of them will see many patients over the course of their careers. And they don't need to know a lot about the biochemistry of the disease. That's not what we're trying to do here. But they will need to know how to recognize some of these diseases so that they can take the actions that they're trained to do to stabilize the patient and promote recovery. And those are the important points that I want to get across today.
So great. So you're saying we don't actually need to be experts in biochemical pathways.
You don't need to know pathways to do this. We will try to fit it into what most physicians are used to doing, and then you can let people like me worry about the pathways afterwards.
So I think the key thing for us is we don't want to miss one of these cases. So as we're going to go through tonight's webinar, why don't you give us some thoughts as to what are some of the key things that we should be looking for when dealing with a potentially unstable patient who's not doing well as a result of a metabolic condition?
Absolutely. And so we will talk a little bit about the background of some of these conditions, but I want people to remember that as an emergency room physician, I know their priority is in stabilizing that patient and helping them move towards recovery. And so we're going to focus on some of the basic goals that they would put into place in order to accomplish that.
Awesome. Look forward to hearing about these cases.
Thank you so much. So let's talk about emergency management for inborn errors of metabolism, or sometimes what we call for short metabolic diseases. The objectives today are to describe to you some of the immediate management that you could use in patients in the emergency department for these inborn errors of metabolism. But I also want to highlight the importance of implementing treatments in the emergency department that are actually going to shorten the hospitalization or hospital stay of those patients. I also want to give some examples where physicians can recognize in the emergency department some of the features of a metabolic disease and treat their patients more effectively. So let's go through some cases then. And I think this will give some example and context to physicians. I have a pediatric case and I have an adult case. Let's look at this pediatric case. This is a 4-month-old infant that was born in Alberta and then admitted to hospital and came through the emergency room at one of our local hospitals. Had a flu-like illness, which many doctors have seen, of course, and vomiting, not an atypical thing for a child. And it was actually an emergency room physician that got a creatine kinase done. They came back quite high, over 13,000, and then general pediatrics was alerted and this patient was admitted. They initially suspected some type of muscular dystrophy with such a high CK, and the child had many tests done. Interestingly, the child had a normal newborn screen. So it was a mystery as to what's causing this high CK. But people were genuinely worried about this because it needs an explanation. So that's something that is an example of, it seems out of the ordinary, CK 13,000 needs an explanation. Now, we're not going to go through this whole diagram here, but I just want to show that a lot of the things emergency room physicians would consider would be things in the green side of the category. Is there sepsis, especially in an infant? Is there a drug, toxin, some sort of injury? And you can see on the top right is a small section for the metabolic muscle diseases. And I think that went through people's minds when they were thinking about this baby. But most of the things that you see on the right are actually genetic conditions. So rightfully so, the doctors were thinking about, there's something going on here that's out of the ordinary. We need to admit this baby, not just discharge them. I've shown here in this diagram what happened to the CK. And you can see here that CK when the baby presented on the far left was pretty high, but the baby presented again with an even higher CK, this time hitting almost 40,000. And at that time, we were able to treat the baby with energy supply, which is dextrose, because the baby can't burn fat. So we didn't want to leave the patient fasting. But the basic care was started in the emergency room by making sure this child was on dextrose and not just any other fluid. So that's the take-home message from this case is sometimes the only fluid that has dextrose in an emergency room is plain D10. And for a metabolic patient, initially that plain D10 is better than most other types of fluids because of that energy issue. The emergency room physician started this baby on D10. The baby eventually recovered and was discharged. Didn't really have a diagnosis at that time. And over some time later, we ran a genetic test, and this baby was diagnosed with carnitine palmitoyltransferase 2 deficiency, which is a mouthful, but that all started by checking that CK in the emergency room and thinking there's something wrong here. We need to investigate this further. And I tried also, added at that point, a new therapy called triheptanoin. So that's a specialty therapy that somebody like me is going to start. So that's one example, a pediatric example that presented that way.
So in this particular case, the CK happened to have been ordered serendipitously, accidentally even. What tip would you give to the emergency physician seeing a 4-month-old that would make them clue in and maybe make that amazing diagnosis by adding the CK when they would have not ordinarily have done so? Is it flaccidity? Is it something about the baby that would have made them say, maybe there's something else going on?
So most of the time what we say is think about things that if the baby is having a flu-like illness, did the baby actually have a fever? Are there any signs of illness somewhere? If there are no signs of illness, then a decompensation may be there for another reason. Is a baby not feeding? Is a baby vomiting? Is there something that doesn't explain what's going on? And in this particular case, as you said, the CK was ordered serendipitously. But one can also think in which cases one might order this when the pattern, the physical exam, the presentation seems a little strange. And then you start looking for a few basic features of a metabolic disease.
So an unwell baby, no clear explanation, that's when you would cast the wider net and get the CK?
Absolutely. Not just for the CK, but you may consider doing a few other things which we'll go into later. So let's go through an adult case. This is a 32-year-old male. It's a patient of mine. So he presented at a local adult hospital with a flu-like illness. But what's different here is I've already diagnosed him with a fatty acid oxidation defect. He had a management letter. And when his CK was initially tested, it wasn't really that high. It was above 5,000. It's a lot lower than the baby in the other case report we had. And there may be many situations where a CK of 5,000 might not get admitted. He showed the emergency room doctor the management letter, which is another important part of this presentation, is the patients that have been diagnosed will usually have a management letter. And it's an important question to ask when things look a little strange. So here we have a CK of 5,000. There's been no trauma. There's no sepsis. And the patient was alert and was able to say there's a management letter. And that management letter provided some clues as to what to do. Now, this patient already had a diagnosis of CPT2 from a skin biopsy I did earlier when he presented many years ago. Let's look at his course and presentation. And I know it's a bit of a complex graph, but if you can just follow me for a second, the left side of the graph shows his management in the emergency room, where rightfully so, they started him on 10% dextrose, as the management letter stated. That's a starting point. And sometimes we may have to really crank things up a notch. So if we look at his CK, it is still rising on 10% dextrose through a peripheral IV. And it went as high as 56,000. At that point, seeing that that was not enough, myself and his physician that was attending to him made a decision to put a central line in to start some special fluids, which you normally would not think about. In this case, it was 20% dextrose, half normal saline. We know we don't want to give just the dextrose, so we mix it with some saline, which is done by the pharmacy. In some places, this may not be available. I know I've had calls from ER physicians in hospitals around the country that are in smaller centers where this is very difficult to make. The preference in those situations would still be to use the plain dextrose because that metabolic disease will get worse. But here, of course, in a tertiary care center academic hospital, we were able to get our fancy solutions, D20 half normal, and we ran it at a pretty high rate. An energy deficit might make these patients worse. So we doubled the energy supply to 8.24 milligrams per kilogram per minute of dextrose. The issue there is it's going to cause the blood glucose to go high. So then we made sure we were ready to start insulin at the same time. A bit of a provocative move, you might think, with somebody who presented with a CK of 5,000. But you can see the result in that he had a rapid decline in his CK afterwards and a really uncomplicated course in the hospital. In another situation where actually the patient refused to get the central line, that patient had a CK go to 400,000. We had to bring him into the intensive care unit, and he was there for a good week before we could dialyze it off. And that's the difference between the early intervention with fluids and sometimes insulin versus just letting it follow its natural course.
And that degree of osmotic load cannot be given through a peripheral line. That's the justification.
Absolutely. And that's the discussion we had with the physicians, is that we would not be able to give D20. So these are things that can be accomplished, certainly in some of the larger centers, and it's not hard to do in those centers, but they are important decisions to make. If this patient was in a center that did not have access to this, I would ask for a transport actually to a center that can put it in, and we've done that multiple times in the past. This patient, because of that early intervention and management, made a full recovery and is doing quite well. I saw him in clinic a couple of days ago. His CK is still a little bit high. It was around 1,500, but he's doing well and it will eventually recover.
So that's great. What I think that case demonstrates is the incredible value of the management letter. And hopefully it's either in the electronic health record or the patient always knows to bring it with him. What should the emergency physician be really focusing on in reviewing that letter? And when is it that they should really be considering calling you or getting expert advice on how to proceed with what the instructions are in that letter?
That's an excellent question. I like to be notified whenever that patient comes in because each situation is a little different. And so I might ask some questions regarding the history. I might come in and see the patient, which I often do, to see what is different about this situation. Do I need to do something earlier? You know, the saying is an ounce of prevention is worth a pound of cure, and that really applies here. So that early assessment is very important. So the ER physician should actually notify the metabolic service as soon as that patient arrives in the emergency room to notify them that this patient is there.
24/7.
24/7.
Music to my ears.
Yes. And in many jurisdictions, there is an on-call metabolic physician 24/7. We're fortunate enough to have that here in Calgary, and I know that exists in Edmonton, Vancouver, Toronto, many of those places. What I say to many physicians is, even if somebody's not on call, at least call one of the academic centers to see if there's some advice, even if you don't have somebody locally that can give you that advice, just to know where this is going. So that management letter will detail for the emergency room physician what the management plan is, whether that patient needs to be transported early, whether they need to be started on any medication right away, and all of that will help a situation from getting worse.
That's awesome. Thank you.
So when we think about metabolic diseases, most metabolic diseases are rare diseases, and rare diseases actually affect 10% of the population. So if you took 10% of the population, then you can see you probably have seen some type of rare disease, and some of those patients will have an inborn error of metabolism. So 3 million Canadians have some type of rare disease, and there will be a proportion of those that are metabolic diseases. And a metabolic disease means there's a genetic disorder of metabolism. With some exceptions in some of those clinical trials I've been involved in, you can't change those genes. So the patient has a predisposition to getting very sick unless some intervention is taken. And this is the simplest diagram I can draw for you. Is in most metabolic diseases, the general premise is that you have a compound or a group of compounds that go through some type of enzymatic reaction to produce something else. So A plus B going to C. And either you don't have enough of C, such as hypoglycemia, or you have too much of C, which is something like hyperammonemia. So you may need to support to improve the level of something, or you may need to remove a toxin that's accumulated. There's more than 400 metabolic diseases. I don't know them all, so I wouldn't expect anybody to know them all in the emergency room. So we'll deal with how they present and how the body reacts to them. And there's generally two basic problems to deal with metabolic diseases. There's one added one here that on top of what most emergency room physicians would deal with. So you have to deal with the acute decompensation. It could be a blood glucose issue. It could be sepsis. It could be something else like that. But you will need to consider that there's an underlying genetic disease that makes that person's physiology not respond the way you might think. And that second component is going to be important in getting them to recover. So you treat the acute decompensation, airway, breathing, circulation, because it doesn't make any sense trying to fix a glucose if there's no airway. So you would do all the normal things you would do. And then if something looked a little bit off, something not ordinary, then you would consider, could there be a metabolic disease that we also have to deal with? Now, this is the main reason we want emergency room physicians to consider whether their patient has a metabolic disease. Because the natural history, remember it's a genetic disease, so we haven't fixed the genetic basis. The natural history of an acute decompensation in a metabolic patient is either death or severe brain injury, and it can happen very quickly. So a patient such as a baby presenting with an ammonia for more than 400 micromoles per liter, may not survive the next 24 hours unless there's treatment. So the same can happen in adults as well. And so it's important to remember that things may move very quickly in patients who have an inborn error of metabolism. And without going into too much detail, there are a few basic groups of diseases which emergency room physicians may need to be aware of. For example, glycogen storage diseases, where the body has a problem using the glycogen that's stored in the liver. They may present, and they tend to present, with hypoglycemia, which is a common thing that I think pretty much everybody gets tested for when they come to the emergency room. And they can have lactic acidosis, which on most blood gases, you would be able to detect and see if there was something going on. There's another group, though, that's a little more silent, and these are the fatty acid oxidation defects. They may show hypoglycemia, but that's pretty late in the game. And a lot of times when I get called by emergency room physicians, they say, we have a patient here with the fatty acid oxidation defect and the blood glucose is normal. So I think it's okay. We're just going to send them home. But the difficulty with that is the blood glucose is the last thing to change before a patient crashes. So we still need to go back to those two principles, which is treat the major problem that's happening, but think of the underlying genetic disease. And in this case, it would mean providing glucose support until the patient is ready to go home. So that's where that other consideration comes in. Another way these patients can present is with rhabdomyolysis, and sometimes they may not even have a lot of symptoms. In fact, when you or I were talking earlier, we said that serendipitously some of these are found through the emergency room because emergency room physicians are thinking about what's going on and they may have ordered that CK, and that gives them a clue as to what's happening. And also another major way that fatty acid oxidation defects can present is cardiomyopathy, some type of arrhythmia, some type of hypertrophy. And I know that's such a common thing, but we may see that in young adults, and it's those clues that say, this is a little off. Why would a 21-year-old have cardiomyopathy or an arrhythmia? You tend to see that in older patients. And so somebody looking at those patterns might think a younger patient, this looks a little strange, and maybe this may be consideration for some type of genetic or metabolic disorder. We also have urea cycle disorders, where it's ammonia that is really the problem. And those patients will have a clinical feature, typically of encephalopathy. That's something they have. So this one's a little tougher, the next one. And I wouldn't expect this to show up for the first time in adults, but it does happen sometimes. We've had patients admitted, locally and other places that I've worked in Canada with maple syrup urine disease. And no, you wouldn't test this by tasting the urine in patients to see if it tastes like maple syrup, but they tend to present with encephalopathy and a lot of ketosis out of proportion to what's going on in the child. The organic acidemias, and I know now we're getting complicated with these terms, but these are a group of conditions where they can have a metabolic acidosis, they can have ketosis, but some toxin is accumulating. And if we go back to that A plus B equals C, it's that C that's accumulating, and we're going to have to get rid of it at some point in order for them to recover. And lastly are the mitochondrial disorders, where you'll have muscle weakness, you can have lactic acidosis and decreased energy production. Now, I can tell you patients in each of these categories have presented at each of our hospitals in the last year. And in most centers that see a lot of patients, you may see patients that have these type of disorders. In some areas, you may have a particular disorder or a group of disorders that are very common to that population. For example, in northern Saskatchewan, there are many people who have a high ammonia disorder called Triple H syndrome. And when they come to the hospital, the closest ammonia is many hours away at another facility. And so when they call me, we have to deal with the situation with what we have, and sometimes not necessarily lab tests. So the clinical presentation is very important to consider. Why is this patient presenting, and what kind of symptoms do they have? So one token pathway for the fatty acid oxidation defects. When we think about how our blood glucose is defended, we think about glycogen production, we think about glycogen metabolism, we think about the Krebs cycle. Well, I don't know that everybody does, but I do at least. And we think about mitochondrial pathways. And that's important because when we look at how our bodies burn fat, a lot of that fat has to go through mitochondrial pathways in order to be burned. On this diagram here, we can see in the figure, we've shown a picture of the heart. And the heart is very interesting because the heart in general likes to burn fat for energy, because we all know what the brain is doing all the time. It's trying to be the hog for glucose. So the other organs have learned to metabolize fat, and that's where you'll start seeing some of those changes. And then you have the pathways there shown in color. I won't go through all the names, but you have to get that fat inside the mitochondria. And there are proteins that govern the movement of fats into the mitochondria, and then how that fat gets used. So you'll see in the diagram there LCFAO, and that stands for long chain fatty acid oxidation defect. So these long chains are things like if you're having dinner and there's olive oil in the dinner or something like that, those are long chain fatty acids. For your body to use them for energy, they need to go through a specific pathway. If there's a genetic disorder where that pathway doesn't work, then the body can't use that for energy. And you know, one of the things that happens then when the body can't produce energy is the blood glucose is going to fall. But other things might happen. The heart may not work. There may be an arrhythmia. There may be rhabdomyolysis and so on. So these are a group of genetic disorders where the body can't use fat. We see this in adults where they may have the organ disease, cardiomyopathy, or they may show with rhabdomyolysis or muscle weakness. We see it in babies in particular when around 4 to 6 months of age, they are supposed to be sleeping through the night, although a lot of parents will tell you they don't, but they're supposed to be able to tolerate going through the night because the body converts to using fat. And when they have a genetic block in a pathway, that's when they run the risk of running into trouble. And there was a time we used to see a lot more sudden infant death syndrome in babies when testing for fatty acid oxidation defects became part of their newborn screen. We're seeing much less of that actually. So we're getting that answer from the dry blood spot before they come in, and that's a good thing. And it's mainly to pick these sort of disorders up. So that's the main message I want to get across here is with the fatty acid oxidation defects, that block in using fat for energy becomes a problem. And there's only really 2 things our body uses for energy, fat and glucose. So the basic message then is we would support that patient with glucose. If we don't put glucose in the patient, then the patient is at risk for going into a worse situation because the fat can't be used for energy. So the key take-home message from this slide really is if there's a genetic problem with how the body uses fat, then we have to give another energy source to help it recover. So some of the common features that we see in metabolic diseases is that the body loses its balance, its homeostasis, and we have to find a way to restore the balance, usually with energy and other agents and specialized diet. And a catabolic state where the body is starving. So what I see sometimes is many people are put on normal saline for long periods of time without any external energy supply. That can make them worse. There's not enough nutrients, and the body needs those nutrients to recover. And there could be toxins accumulating, like ammonia or lactic acid, and we may need to find a way to get rid of those. If we don't do all of those things, then organ failure may result. Liver failure, coagulopathy, bleeding disorders, damage to the brain.
Wow, that's a great overview, Anil. But what is it that should tip the emergency physician off and make them think that there might be an inborn error of metabolism? Is it something that's just unique to kids and pediatric patients, or how would this manifest in the adult presentation?
Well, that's an excellent question because I think for a lot of physicians, these have been traditionally things that happened only in kids. And over the years, what I've seen, though, is that many of the adults have these disorders that are undiagnosed, or we have children with modern treatments that actually make it to adulthood because some of these kids wouldn't make it to adulthood. They wouldn't survive that long. So whether you're seeing children or adults, you need to be aware that these type of disorders exist. So let's go to some conclusions. Some of the key points were to consider in a patient that might have a metabolic disease. They often will have a pattern of a sudden decompensation and they were previously well, and there may not be any reason why they decompensated, and that may be the metabolic disease. It could be sepsis too, and that doesn't mean you can't treat the sepsis, but you might have to treat the metabolic disease on top of that as well. Unexplained encephalopathy, unexplained symptoms, something out of the ordinary. Oftentimes it will be an intercurrent illness. So this patient I presented, the adult, he also tested positive for influenza A. That was the tip-off. He hadn't been in hospital for years, but he got influenza A, and then that triggered the rhabdomyolysis. For some reason, metabolic diseases don't like viruses, and those two don't go well together. Some of the key indicators when something is really wrong is a blood glucose, a blood lactate, metabolic acidosis, a high CK, or ketonuria in excess of fasting. That goes back to the maple syrup urine disease part. When I was in Toronto, we had families that lived closer to London that would come to Toronto who had maple syrup urine disease. And one of the things they would present with is excess ketones in the urine when they actually hadn't been fasting very long. So core indicators, which you can get in virtually every emergency room, would be the cardinal signs that something is off. The other thing that's a take-home message here is the importance of energy. In a metabolic patient, 10% dextrose is your go-to solution. If you can get crystalloid, you can add crystalloid later, but in many cases, it's more important that they get 10% dextrose. Running at least maintenance, and sometimes we say 1.5 maintenance, such as the management in the adult patient when they start in the emergency room. A lack of that dextrose may precipitate a decline, and we're talking hours. You also want to consider what's readily available. So sometimes people will say 2/3 and 1/3, or D5 something. I'm like, whatever you got with dextrose, throw it on there, and then we'll go and figure out what else we need to add. What's important to remember is IV fluids alone will not lead to recovery. They are a stabilization, in fact, a resuscitation measure. For many of these diseases, it's actually the special diet that gets them back to homeostasis. So that means there's going to be admission, because the time to recovery is going to be longer than what most patients spend in the emergency room. They will need to be admitted, get back on their diet, usually before they can go home. Check to see if there's a management protocol. That's going to help you out. Always ask if there's a management protocol. I tell my patients all the time to say it to the ER physicians, but they don't always do that. So it's always good to ask, if you have a metabolic patient, do you have a management protocol? And the basic strategies are still to do your ABCs and then treat any situation that's causing them to get worse, like an infection, and then also consider you need something for the metabolic disease. Any one of those that are missing, then that patient could run into trouble. So the time course, most of these patients will likely need to be admitted. What I often say, and I know it's not always the case, it's about 3 days until we get this thing under control. So if they're an adult, they would go to a hospitalist service or internal medicine. And fortunately, in Calgary, we have those arrangements, but I know those arrangements exist in many other cities as well. If it's a child, then they would go to a pediatric service. They may have specialty medications. So especially if there's a management letter, that means they could be on specialty medications, and the hospitals won't stock those. And then when the parents are bringing the child in, whether the child is an adult or an actual child, then they may be too rushed to think about bringing the medications. The hospitals won't stock these. So it's always a good idea to say to the family, whatever specialty medications or formula you have, can you bring it in right away, or get somebody you know to bring it in? And a referral is generally a good idea. There's many of these rare diseases out there. Some of them I've never seen, or I might only have one case. And it's important to understand that the management in those situations might require a specialist to sort of carry things through after you stabilize the patient. And refer to the physician most familiar with the patient, because they know the history and all the nuances that have been going on with that patient.
Anil, that was a great discussion, and it's a fascinating topic. Let me see if I can just put it all together for my emergency medicine colleagues. I mean, first of all, these are rare diseases, but there's still an enormous potential to miss something and to have a bad outcome. So like many safety incidents, they're rare, but we need to keep some vigilance and hopefully have mechanisms in place where we won't miss an important finding or an important treatment plan. I think the take home from my point of view is that if something seems not right, be it with the small infant or the adult even, it's important to remember that not all muscle aches or muscle weakness are benign. Think about getting that CK. While you're there, consider adding an ammonia, especially if there's encephalopathy. Check urine ketones, and if those are elevated outside of a fasting context, be suspicious. And of course, in a baby, get a cap gas, get a VBG. That can also clue you in. And I think you've highlighted beautifully how important these management plans are and how they can be an important guide and a life-saving intervention. So thanks for that discussion. Thank you for joining us, and we hope to see you next time.
Thank you.